VeriChip, soon to be Positive ID, we have expertise in signal processing and RFID-enabled communication. So by integrating all these pieces at the get-go of the process, we would eliminate, or at least reduce, some of the roadblocks along the way. The goal here then is to give the diabetic a reading that tells them, is their glucose level in the safe zone, or is it either high or low, and they need to take corrective action. Well, again, the way this actual device would look, it has to have a sensing system, has to have an interface with the human body and its fluids. That's what RECEPTORS is bringing to this project. And it has to have a signal transduction from the glucose sensing into an ASIC, into an RFID communications module, and that's VeriChip for Positive ID. The actual device will need to obviously be fairly small. The exact size, I think, is a little indeterminate at this point. A goal might be to be the same size as the current VeriChip microchip, although it could be a little bit bigger depending upon the goal in terms of how long a particular device will last. If it lasts a very long time, the patient can tolerate a slightly larger device in exchange for not having to have an implant nearly as frequently. So again, the key components, the bioisolation part, the signaling agent part, as we call it, is a competitive closed cycle interaction, and then our selective binding system. And these two work together. This bioisolation prevents fouling materials from getting into the signaling device, but also it prevents any of the materials from getting out. So it becomes closed cycle. It's able to cycle again and again and again, and becomes a long-term solution for the diabetic. Our CARA, as we call it, C-A-R-A technology, will build the competitive binding material. We're very good at that. We've been spending 7 years developing the workflows around this technology. These competitor agents are also synthetics, again, as I mentioned, so that we can scale them. They're also robust and stable. And we're incorporating 2 different layers of biocompatibility into the design and into the preliminary experiments to allow glucose to exchange normally, so you get real-time readings, and also to prevent fouling of the system. What's critical in this design is we have to balance sensitivity and specificity. By sensitivity, I mean if you have a target glucose level, normal glucose is around 100 milligrams per deciliter. Normal range is about 80 to 120. If you have that target range, the system obviously has to be able to respond to that target range, otherwise it's not going to be of value. But you also have to have a level of specificity, i.e. how specific it is for glucose. There are a few other sugars that are floating around in your bloodstream. You want to not get false readings off of those, especially galactose, which ranges quite a bit. And so you have to balance the need for both. So you have to coordinate your identification of components. Whoa, didn't want to do that. I knew I did that at some point. You have to coordinate the identification of the appropriate sensor components to give you the specificity and sensitivity criteria. So the way the system was designed, we set up 2 subphases in phase 1 where we actually built the materials, the competitor agents, the screening, what we call arrays, the membrane materials, and we identified candidate or lead, if you will, systems that had the appropriate glucose binding, needed to have the appropriate competitor agent, what the competitor agent was built from, and then the appropriate response. And that's what we're able to report today, that we took this system and the different parts of the system. We have a very high throughput system, so we can screen thousands of possible combinations in a fairly relatively short period of time. Bill and Scott might have not have thought a few months was relatively short, but we did for the amount of screening we did and were able to do. And that's really critical because if you end up in a preliminary screen with a very small number of possibilities, and then that possibility falls by the wayside, you're back practically to square one. Whereas if you have a database that you're able to build, that we were, as we then move forward to optimizing the process, we don't just have a single lead, we have multiple leads that we can serve to optimize. And so the end of phase 1 was that we did produce a tunable glucose response with these artificial agents. what we're looking at now, what we've begun, is phase 2, and the first part of that will be to optimize the building of these materials so we know that we can scale them up as we go towards prototype, optimize the biocompatibility of the membrane components, and then optimize the entire system on a bench scale, and incorporate the all-important, what in my work we call the matrix. The matrix in this case being blood, the matrix being interstitial fluid. It's one thing for somebody to come out and say, oh, I've got a glucose sensing system and here it works in buffer or water. That's not really going to get you anywhere. You have to be in a real environment. So all those pieces will be coordinated and combined in this phase 2 study, which will then lead to phase 3, where we'll actually get to a relatively smaller prototype, which can then be miniaturized. So I do have an animation, just to give you a little bit of an idea of how the system works. And it just takes a second to... Where are you?
We do not have that.
Nope, that wasn't it. Come on.
They have it where they're at. I think
there we go.
This is where it's supposed to be, but we don't have the quick time.
So this is, again, a project we're doing with VeriChip and RECEPTORS. The idea, and it's not quite sure where the device will be implanted, but again, the device will have its electronic signal transduction. This is the sensing system that we've proved as a proof of principle, and we'll now go forward to produce a prototype of. This is glucose, the little yellow dots. This is that competitor agent, which is based on mass, and it competes with the glucose for binding to our selective, our smart material environment down here, and signal transduction then occurs below that due to changes in mass at the surface. These competitor agents have a fairly high mass relative to the glucose. As the glucose molecules, as they increase in the fluid, these materials, the competitor agents, are released. That causes a change in the dynamics of the surface, which can then lead to a signal transduction event. So as you can see, it's a closed cycle system. Glucose comes in, these materials go out, but they're still captured within the environment of the sensing system by the selective membrane, so they can't release out into the body. So then you can visualize that as glucose changes, those relative concentrations at the sensing interface will change. So in this particular case, if the diabetic gets a very, very high reading without having to prick their finger, then they institute whatever remedial response is appropriate, leads to a reduction in the glucose concentration, leads to a rebinding of the competitor agent, change in the signal, then giving the patient the appropriate feedback for what they've accomplished, and eliminating, again, the finger prick. And I think, yeah. So the other that I want to talk about, which is diabetes, is obviously a chronic and a long-term problem. Right now, pandemic influenza is a little more on everyone's mind. We probably all at this point know somebody that's managed to contract what they were told was H1N1. What is important to note, if you actually find yourself in the clinic in not too long a time, unfortunately, is that the clinician or their assistant will use a quick test. It will come up positive or negative for influenza A. If it comes up positive, the CDC has told them, we can't deluge all the labs with the expensive testing. Just assume that it's H1N1. So anybody that's getting told it's H1N1, it's an assumption at this point because the tests don't exist. But it exists, but it's what's called a polymerase chain reaction test, which is much, much more expensive. Allison had the pleasure of having her daughter tested that way, and probably hasn't even seen the bill yet, but will. So what we're focused on is the idea that our technology, and it's built now, again, on the same type of sensing system, so we're not having to start de novo, is building a point-of-care diagnostic for all types of influenza. So here's the beast, which I thought all of you might find at least vaguely interesting. This is an electron micrograph of an actual influenza virus. I think, in fact, it's H1N1, but I don't remember for sure. This is all the nuclear material